So actually, it's a little bit unorthodox because I speak after Jasmine, who had this, advanced disease and all this treatment. And I will make an update on the skin-directed therapies and focus on chlormethiamine gel, which actually we have experience in Greece since 2018 for the last 5 years. And based on all the guidelines, this is a stage-adapted treatment, so skin-directed therapies are preferred, as said in so many lectures before, for the management of early-stage disease. And Proclipi, which is an international consortium, also collects data on treatment, and this is the first publication on treatment of early-stage mycosis fungoides from Proclipi, and Pedro Coaglino is the leading treatment project author for these treatments. And there are almost 400 early-stage disease patients, mostly 1A and 1B. They were included in this database. As you can see here, the summary of treatment registered at the first visit. Most of the patients are using topical steroids, then 20% of the patients UVB, and the other 20% PUVA, and the rest of the patients have systemic treatments. So when he tried to analyze this treatment pattern, it seems that as patients come, the first line treatment is a skin-directed treatment, and very few patients are treated with systemic treatment. But when the patient relapses, it's more frequent that the physicians are considering treating with systemic treatment. So the gray bar there, I don't know if it's, I cannot point there. It's the gray bar is the skin-directed treatment, and the black one is the systemic treatment. So as the more times that the patient relapses, then all of the physicians are considering changing from skin-directed treatment to systemic treatment. And according to patient characteristics, it seems more likely that patients with, when the patient presents with plaques or folliculotropic MF or more extensive disease, the physicians are more likely to use a systemic treatment. And this is the multivariate analysis of these parameters associated with a more frequent visit for a systemic approach. So disease characteristics such as the presence of plaques and the presence of folliculotropism influence physician choice for a systemic regimen. And skin-directed therapies, however, show better response rates compared to systemic treatment. Now, what is new in topical treatments regarding the first-line treatments, it's the addition of this chlormethiamine gel for the last 5 years in our practice, and this is incorporated as between the first-line treatments in the EORTC consensus for the treatment of mycosis fungoides, and also as maintenance treatment for MF and Sézary syndrome. And all the major guidelines, they recommend the use of chlormethiamine gel for a first-line treatment in adult with MF as a monotherapy in early-stage MF and in combination with other systemic treatments in advanced stage disease and as maintenance treatment. So it can be used in early-stage disease, can be used in combination with other treatments in systemic disease, and also can be used as maintenance treatment. And this is the NCCN guidelines. They also incorporate in skin-directed therapies the chlormethiamine gel either in skin-limited disease or generalized skin involvement. And here, as you can see, topical chlormethiamine can be used in all stages. And this is a gel applied to the skin. It's quite stable, and it's a bifunctional chelating agent which binds to DNA strands 1 or 2 and leads to apoptosis of the cell. And this is the pivotal study actually compared this gel to the compounded ointment, and it was found to be non-inferior. Actually, it was found to be faster, to produce a faster response and actually a higher response rate. And the main side effects are skin irritation, which actually was manageable, even though it was in higher grade, like rate, more than 50% of the patient had dermatitis. And the proof study is a prospective observational study, actually included patients not only with early disease, but also with advanced stage disease. And the patients were applied meclorethimine gel once daily. And also the clinical response started from 1 month, but the peak response was at 18 months. And the results were good across all stages, including, of course, stage 1A and 1B. And regarding the side effects, they were not unexpected or serious side effects. The most common side effect was dermatitis. It seems to be similar to the pivotal study. However, in this study, patients were allowed to use also topical steroids. And we tried to gather our experience, and we had two publications, one in 23 patients and one in 58 patients in 2022. And these were from 3 university hospitals in Greece, and it was patients with plaques and tumors. And the gel was applied once daily. It was either monotherapy or combinational therapy. And we assess efficacy, safety, and quality of life. The base, we assessed the ORR, ORR4, time to response, and time to best response, which we found it's a good marker for early stage disease, because can describe the best response in these patients, because as we said, the response might take time to the patients may need more time to achieve their final response. So these are the demographics and female to male patients. Most of the patients had this as monotherapy, but there are a large number of patients also using meclorethimine gel as combinational therapy. Now, as we can see, the ORR was increasing with time, and we see that it started from the first months, according to the pivotal study, but the best response was at month 9, and this is the CR, and as you can see, the CR also was increasing with time. And this is partial response, and almost 50% of the patients achieved a PR at the 6th month. And then the patients with stable disease was diminished with time, as well as patients with progressive disease. So the CR, the best CR was at 9 months, the PR was 50% at month 6. And the stable disease patients were diminished with time. Actually, regarding skin lesions, the type of skin lesion, patients with patches achieved 70% of improvement at month 3, which is the best response. And patients with monotherapy achieved a better response compared to patients with concomitant therapy, mainly because these patients were early stage disease patients. And time to response was 12 weeks, sorry. It was, we need more time for the patients to respond. And time to best response was 22 weeks. So some patients responded at week 12, but they needed more time to get a better response. So a patient may achieve a PR at the third month, but then you need more time to wait, and maybe the patients may achieve a CR. So this treatment needs more time to have a better response. And compared to the pivotal study and proof study, again, ORR was increased with time in all studies. Now, safety, as said before, dermatitis was the main adverse event, but it can be managed with reduced frequency of the gel, like use the gel 2 times a week or 3 times a week, apply emollients, sometimes apply topical steroids if a patient cannot tolerate the combination with emollients. And rarely we need to stop the treatment and until the irritation is resolved, and then reapply gradually. And there are very few patients that actually experience a severe dermatitis with the need to discontinue the treatment. And this is the percentage of our patients that need to discontinue the treatment due to dermatitis. Now, we try to correlate the presence of dermatitis to the response, and there was no correlation between the presence of dermatitis, of the severity of dermatitis to response, so the development of dermatitis does not really affect the change in response. And MSWOT and Skindex improved with time, and there was a correlation with the changes in MSWOT and Skindex scores. So I will present you a few cases with either early stage disease or advanced stage disease. And this is a patient with folliculotropic MF. He had interferon. He fluctuated a lot. And we started in 2019 with chlormethiamide gel. And he improved. He almost got an MSWOT of 2. And this patient is one of our first patients, and until today he uses the gel, and he has a very good response in combination with interferon. So it's a good, it's an interesting combination, interferon with the meclorethamine gel. So this is another patient with a single folliculotropic patch. And as a monotherapy, it really cleared the skin. It left some hyperpigmentation, but there was no evidence of MF on this lesion. The third case is a woman with 1B folliculotropic MF, and also she had several treatments like PUVA, acitretin, and she had a TSCB, but she relapsed, as usually with this patient. Then she had some methotrexate, interferon, which she couldn't tolerate, and then she started on topical treatment with meclorethamine gel, and actually she had a complete improvement on her small lesions, sometimes tumoral lesions on her neck, and this is her after some 6 months and 12 months, and until today she is using topical meclorethamine gel, which she tolerates actually very well. And the last case is a patient with a folliculotropic MF, stage 2B, and he was started on interferon A, and he actually, we added meclorethamine gel, and he had an improvement, and he still continues with the gel. He actually had some tumors, and he didn't want to have a radiotherapy, and we used this gel to treat this tumor on his chest. And this is him after some months of treatment, and his plaques and a large infiltrated plaque on his back. So he's still using the combination on interferon A and ledaga and meclorethamine gel. So meclorethamine gel is effective in all stages of MF. Patients with early stage MF may have a higher response rate, especially patients with patches have a faster response rate. Response rates increase with time. We have to wait until we see the best response of these patients. And we have to highlight to the patient that it is important to wait and continue the treatment. And response will come with time. And dermatitis might occur, might be, usually is not difficult to manage. And very rarely leads to discontinuation of the treatment. We can reduce the treatment frequency, add emollients, and sometimes we add topical steroids. And actually, the addition of topical steroids did not change the response of the treatment. Actually, I would like to thank you and I invite you to Greece to our regional